everyone. It is officially noon. So I have the honor and privilege of introducing Dr. David Hong, who is an associate professor of psychiatry and behavioral sciences at Stanford University, where he serves as a clinician scientist investigating the role of development in child and adolescent mental health. Much of his work centers on examining biological mechanisms that may impact clinical trajectories in youth, particularly through the lens of sex as a biological variable and gender identity. This includes ongoing work investigating longitudinal outcomes spanning the early pubertal period in transgender youth, as well as studies of sex chromosome to better understand contributions of X and Y chromosomes to neurodevelopment. More recently, Dr. Hong has also developed interest in leveraging digital mental health tools and clinical informatics to address critical questions in child mental health. He serves as Associate Chair of Clinical Research in the Department of Psychiatry and Behavioral Sciences at Stanford, as well as the co-director of the Stanford Mental Health Technology and Innovation Hub. Please join me in a warm welcome. Thank you so much. All right, passing the mic.
Thank you for the kind introduction. It's so good to be here, seeing some familiar faces. I actually don't think I've been on campus since the last time I was at Parnassus, so this is a huge upgrade. I'm so impressed with the space. I'm gonna jump right in. Oh, sorry, is that for me? All right, I'm gonna jump right in, and we have a lot to cover. So today I'm going to discuss parsing heterogeneity in child psychiatry through the framework of sex and gender. To go over my disclosures very quickly, I get funding from the NIMH as well as a number of foundations, and I also have served on the board and received compensation for Little Otter. So for today's agenda, we're going to cover a broad category. I'm hoping by the end of this, you'll be convinced that it's really important to think of these variables such as sex and gender more broadly. And we're going to do that by looking at the broader context of mental health in child and adolescent work, which I think I'm preaching to the choir here. And we need to think about it in a couple ways. So first, we're going to orient ourselves to the developmental framework. And then within that developmental framework, what is the role of sex and gender on psychopathology? I'll hopefully overview for you things that you may know about the mechanisms by which sex and gender might impact brain development. And that's really through genetics and hormones. And then we'll use a couple of case examples of the work we do in our lab. Primarily, we're going to focus on sex chromosome aneuploidy, such as X and Y variations, Turner and Klinefelter syndrome. And I'll briefly talk about transgender adolescent work, which I right now is a longitudinal study. I'll present some of the baseline data. And then we'll synthesize it and just loop back. How does this impact all of you who may not be working with kids with genetic syndromes or in transgender clinics? And to think about what can these particular conditions inform us about our work more broadly? So when we think about mental health, we know that everything occurs on some kind of developmental spectrum, right? And I'm going to talk about this within the context of heterogeneity. This is a problem we have both in the clinical space as well as within psychiatric research. If we think about autism as an example, all of us would know that autism is actually a highly heterogeneous condition. So all of us here in this room, we're going to have a certain number of traits that we share in common, and those might collectively be grouped together for the purposes of defining some categories, right? Like we might try to cluster everyone here into 4 or 5 separate groups in order to have some distinct working basis to define a condition. And we do that in the clinical space. So unfortunately, we know that it's not that simple, right? We have quite a bit of inter-individual variability between us. So down at Stanford, we often think of autism not as one discrete condition, but actually the autisms. It's highly heterogeneous. And that's because in addition to all of these shared common variances, we also have a number of unique or distinct qualities that would distinguish one person from the next. And this is an area where we have some limitations in the DSM-5. Our current clinical frameworks as it stands is highly phenomenological. So we're using it as a behavioral classifier that will give us some kind of discrete language that allows us to have a conversation about how to do a diagnosis, about how to formulate interventions and treatments, but it falls short as far as really accounting for the ways that there might be differences that also impact the manifestation of conditions in their symptoms. So what is a better way that we might be able to approach some of these things? And again, many of you are doing this already in your work, as far as about thinking it in terms of development. I can't tell if my slides are progressing here. Oop. Okay, here we go. In terms of development. So here's a useful construct, I think, for thinking about how to conceptualize psychopathology within a timescale. If you look at the DSM-5, we really underestimate the importance of development conceptually, right? We might have a couple of criteria on E where something has to present by a certain age, but in fact, we're missing the idea that actually psychopathology occurs in a very time-locked fashion. And that time-locked fashion, I like to think of it in this iterative model. So over the course of all the way from in utero and prenatal life, fully through the lifespan to older age adults, we have a progression or an accumulation of genetic factors, environmental factors, and then these random stochastic factors that are not controllable. Those many of you are familiar already with the stress diathesis model, right? So from very early on in development, it may not present as a diagnosable condition, but we already know those genetic factors and environmental factors as early as the prenatal period is impacting some kind of presentation on an individual for their risk or resilience to some kind of condition. And then over time, that will interact as they continue through their development with other kinds of factors, again, genetic and highly environmental at that point in the childhood period, where it will ultimately lead to the onset of some kind of psychiatric disease or condition. And it doesn't end there, right? Like it will continue into adulthood, where again, iteratively, those two factors, the biology and the environment, interact throughout adulthood. And that'll really mediate what happens as far as remission to disease, recurrence of disease, persistence of disease. And it's something that, again, we need to think about much more concretely in the way we approach some of the conditions that we work with. And this is something that is already illustrated in the literature. If you look at epidemiological results, we know that development is highly critical. This is a nice meta-analysis of studies where they looked at the onset of psychiatric conditions across the age span. And they looked at, in these illustrations, you can see the peak age of onset illustrated by these numbers, right? So certain conditions like neurodevelopmental decisions, the peak age of onset or diagnosis is typically around 5. Other conditions, it might be bimodal, like in anxiety, it's both in childhood at 5 and then also around 15 in adolescence. And then other conditions you might see are closer to adulthood. So it's not as if these categories of diseases are happening uniformly across development, but in fact, we're seeing it happening in very discrete periods where there should be some accounting for how that's happening. This is essentially the same thing, just looking at it from a numerical table. Again, we as child psychiatrists know that mental disorders, they'll present early on. We'll know very early on, even before it's diagnosed, that there's some degree of symptomatology. So any mental disorder, the peak age of onset is typically by 14 years. And if you look at these columns over here, you can see that roughly 50% are present by the time you're 18, and roughly 60% are present, have some onset evident by the age of 25. This is not a huge surprise to many of us. If you look at neurodevelopmental disorders, again, we just saw this in the prior slide, but you can see that these are highly skewed towards earlier development, right? So the peak age of onset is around 5, and roughly 80% are present by 18 years, and over 95% are diagnosed by the time you're in your 25. Similar for that, that's inclusive of autism spectrum disorder and ADHD, the neurodevelopmental disorders. We see a similar but slightly extended onset course for anxiety-related disorders. Again, early onset, roughly half by 18, and roughly 70% have onset before the age of 25. And then as you get to other conditions, trauma-related disorders, If we look at substance use disorders, schizophrenia spectrum or psychotic disorders, and personality disorders, then we can again see that there's more correlation to adult onset. So in these instances, the peak onset is typically around 19 or 20 years, and then a much lower rate are diagnosed by 18 years, so anywhere between 10 to 15%, and roughly half of them are diagnosed by the time that they're 25 with the onset of some symptoms. So again, if we think back to this, it sort of categorizes development in a way we can think about these very discretely, right? So there's these neurodevelopmental disorders that tend to skew towards early development. We have behavioral, mood, and anxiety disorders that center around adolescence. And then we have these psychosis, personality, and substance abuse disorders that center around adulthood. How can we get additional insight into that? Can we make it even more granular than just thinking about development alone? And the thing that I want to really emphasize today is we'll talk about that within the framework of sex and gender and how those constructs map onto some of these developmental differences. This is a great study from Scandinavia. As we all know, they have a fantastic cohort registry system where this is actually a nationwide study. So it comes from Denmark, and they have maybe 5 million people in their population, and they track the ICD-9 diagnostic codes for every single person in their country that was born somewhere between the 90s and like 2015 roughly. So this encompasses about 1 million or so youth who were born in that age range. And we can see again from that, these are the distributions where they went ahead and segregated it based on sex assigned at birth, right? So the darker blue color is anyone with the girls. On the x-axis, you see the age at which any mental disorder manifests. And then the lighter blue color are the boys. You can see the dotted lines. Those are cumulative incidents over time. And for any mental disorder, you can see again what was just illustrated when we're talking about development, only we see an additional segregation here between males and females. So that early developmental period in that range between 0 and pre-adolescence, roughly 11 or 12 years old, there's a higher separation where mostly males are getting diagnosed with some kind of psychiatric condition. And that flips. It's an inverse relationship that emerges in adolescence, where roughly after 12, girls have a much higher incidence of psychiatric conditions being diagnosed. And again, we can look at it by diagnostic category. So again, if we look at the neurodevelopmental disorders, here we're including intellectual disability or autism spectrum disorder, you can see again, these are highly male predominant. So they happen early, they're skewed towards boys, where, you know, if you look at the overall samples, it's anywhere 2-to-1 male-female predominant. Again, same thing with autism spectrum disorder, anywhere from 2-to-1 to 4-to-1 estimates of boys compared to girls in terms of these diagnoses. There's some evening out that happens at adolescence, and I won't go into depth about that. You know, there's a lot of, we could talk about as far as female protective effects and why those things might be happening. But really, the overall incidence is much higher in males compared to females. That holds true for things like ADHD, another neurodevelopmental condition, which is again primarily male predominant. We're going to talk about some of the factors that might lead to this male-female disparity in greater detail. And one interesting thing is the inattentive type, right? So if we separate out some presentations of ADHD, we don't see as distinct a male-female difference or a sex difference in those things. And then again, as far as non-neurodevelopmental disorders, this is something many of you already know. There tends to be a pretty good male-female equivalence in childhood. So between the ages of 0 to 12, again, we can argue about if boys are getting underdiagnosed for these conditions, but roughly it looks about 1-to-1. Boys and girls are equally affected by mood and anxiety disorders. And again, for whatever reason, there emerges a high female predominance in some of these conditions in adolescence. And even if you look at these conditions in other countries, including if you look at the CDC data in the US, there are very similar parallels also with American youth. So looping back, we now have a construct where we're thinking about things with the development. And then even within that developmental timescale, we can dig a little bit deeper and find that some of those are highly sensitive to sex differences. Am I stuck again? Sorry. Okay, yeah. So in order to have this discussion, it's helpful sometimes to really come up with the consensus terminology. In a lot of prior literature, you'll see that people refer to sex and gender interchangeably, and that's probably a disservice really to the way we currently understand these constructs. So I'm going to use the NIH Office of Research on Women's Health and how they define sex and gender here. So here they refer to sex as the biological difference between females and males. This is inclusive of things like chromosomes, X and Y chromosomes, which we'll talk about in more detail here, sex organs, endogenous hormonal profiles. And then in contrast, they define gender as referring to socially constructed and enacted roles and behaviors. And necessarily, this occurs in a historical and cultural context. So what that means is gender expression will vary across societies geographically and also across time. And all individuals act in many ways that fulfill the gender expectations of society, right? And they posit in, as a scientific construct that it's the continuous interaction between sex and gender by which health is determined. And we're going to use that framework to dig a little bit deeper as it applies to child psychiatry. It's probably overly reductionist for us to think about sex and gender, or sex as just purely the biological piece and gender purely as the sociocultural piece, when in reality, we know those things are not easily separable, right? Like they're not completely orthogonal to each other. But this is probably one of the most pragmatic working models that we have right now. Like it clearly needs a lot of refinement, but it's a useful way for at least us to think about the way to approach sex and gender research. And we can see that they're highly intertwined, even in the way scientific results are interpreted by the lay media or the broader community, right? This is data from the PNC cohort, the Philadelphia Neurodevelopmental cohort. It's one of the largest population-based neuroimaging samples in youth. It precedes the ABCD, which many of you know about and going on now. And a number of years ago, they put out some of the data where they really identified sex differences, for example, in connectivity between boys and girls. And it already interfaced immediately onto the ways we interpret that, as far as being, one title is like, oh, the hardwired difference between male and female brains could explain why men are better at map reading. And a counter opinion said, these are new insights into gendered brain wiring or a perfect case study in neurosexism. So it's hard to do this sort of neurobiological research without having it attached to a ton of social constructs, even in the way that we're interpreting what we think is objective scientific literature, right? And in fact, we wouldn't typically have the same debate about other physical characteristics or phenotypes. Like if you look at height or stature, in fact, we know that there are pronounced sex differences with very robust effect sizes. Men tend to have larger stature and are taller, and women on average have shorter stature. But when we talk about that within the context of brain development or cognitive dimensions, it leads to a whole host of additional inferences that can be problematic. So some of the best research that's looked at this is in the adult space, and this is from the UK Biobank, which is a very large neuroimaging sample, over 5,000 adults, roughly half are male and female. And they in fact replicated some of the things that we saw with stature or height, right? Like if you just look purely at the brain and a number of characteristics, over here on the left side, you have the global variables. So total brain volume, it actually does separate pretty much between males and females in a significant way. The same holds true for total gray matter and total white matter. If you look at regional differences, these are more subtle. Many of these regional or local differences between males and females in this cohort are essentially overlapping, although you might sense that there's some separation in these smaller structures, subcortical regions, the thalamus, et cetera. And what's interesting is this probably tracks to stature or height. So we know that roughly taller people will proportionally also have larger brains. So if we think about it from a statistical perspective, it's almost like this is just a false or latent variable where we're just saying, oh, there's sex differences, but actually it's a height difference that happens to overlap with sex. That's one way to perceive it. And some people have actually studied this. So they compared tall women with equally height matched, shorter statured men and found that there's less evidence for these actual sex differences between men and women. So is there a true sex difference in the brain? In the study, they also looked at this in a little bit more detail. where they extracted out some of those global brain differences. We're going to use global brain volume as a proxy for stature or size here. And if you just look at the raw data, it seems like there's these profound sex differences in total volume and surface area, where men have much larger metrics on those, and in cortical thickness in women. But actually, when you control for the fact that people are just bigger, and in this case, brain volume is proportionally bigger, those differences tend to become much more subtle or largely disappear. So those mean differences in total volume, they go away except for these very specific regional differences. And then in surface area, it has largely gone away much more. Interestingly, those female skewed cortical thickness differences tended to persist even after controlling for volume. So women do tend to have greater global cortical thicknesses than men. Another interesting factor here is variance difference. So what that means, if you compare on that normally distributed curve of all these brain measures, men who have lower brain surface area compared to men on the high end of surface area, they're further apart. The base of that distribution curve is much wider than in women, where the women tend to center more closely together. Yeah, hello. What are the what from? It's general population, yeah. So the UK Biobank, I can't recall off the top of my head how they sampled, what their selection criteria was for creating a population-based sample, but yeah. Yeah, but to that point again about this variance, there's a lot of interesting theories about, again, referring back to this female protective effect, why there might be so much variance in men. So one way to conceptualize that is men are much more sensitive for whatever reason, if there are other insults that affect these kinds of metrics, than women who might, again, have some protective effect where they're going to have a narrower range of distribution when something does happen. So it's been argued in meta-analyses, like if you look at all of these neuroimaging analyses over time, this idea of a sexually dimorphic brain is simply incorrect. Like, why are we pursuing this idea that there's a male-typed brain and a female-typed brain, when in actuality, when you take away that global brain volume, there's actually more similarity than there is difference. And in this meta-analysis, they sort of estimate there's probably only 1 degree of variance if you look at all these neuroimaging studies that might really persist and be valid. And their argument for these authors is that, in fact, the brain is monomorphic rather than dimorphic. It's not useful for us to use that construct. I'm going to argue, if we think about this, in typical development, that is probably the best approach, is that there's more similarity in our variants. Like, 2 women would be more different in their brain structures than 2 men. I think you can make that argument for most of typical development. And again, I think there's a really valid point that most of these differences are driven by stature or size. But if we think about that 1%, depending on the context, sometimes 1% can be highly impactful, right? Like, sometimes that 1% can be something you can hang your hat on and make some really meaningful inferences or data out of that might impact the way we approach things from a clinical framework. And so that's what we'll focus on, how we approach that idea of these actual sex differences that do occur. So I do want to address, before we get deeper into the kind of the biological research I'm going to present, is we have to really acknowledge the fact that there's all these social cultural influences, right? So the very premise of the fact that we're diagnosing these separately, it infers that we're accurate in the way we're diagnosing these conditions, right? And that's probably a fallacy. And we say that because we have a number of gender-based cultural factors in how we diagnose and treat things like ASD or ADHD. And we bring our own social perceptions of what we consider normative behavior for boys and girls, whether it's teachers or parents or clinicians. And that's going to hugely influence the rates of diagnoses and these incidences in the studies that I'm citing, right? And there might also be biological factors that are going on. Like, on a fundamental level, there probably are some psychological domains that are different in terms of social adaptation, aggression, hyperactivity, and how does that interact with manifestation of symptoms that are relevant to child psychiatry. So keep all of that in mind in the background as we sort of go through this other data. So as a sex differences researcher, the framework that we usually use are 2 main dimensions by which we which we can examine sex as a biological variable. One is really the dimension of genetics, and the other is the dimension of hormones or sex steroids, in this case, testosterone and estrogens. You can see that as we, okay, I'll focus on genetics. So you can see that as we're going into the domain of genetics, it's really probably based on the X and Y chromosomes, which I illustrated in the prior picture. So as human beings, this is work that I did with Alan Reese, he's still at Stanford, is we have a very impressive difference in sex chromosome complement. As humans, we're diploid organisms. What that means is we have 23 sets of chromosomes, one from your mother, one from your father. And for the autosomes, for the first 22 sets, they're essentially equivalent, right? There are going to be individual variations, at a more local level, but it's nothing compared to the gross differences between the X chromosome and the Y chromosome, where you can see the X chromosome is roughly 10% of our entire genome, whereas the Y chromosome maybe has like 200 coding genes. So there's a huge difference already between 46XX and XY, even in the sex chromosome complement. We won't go too deep into the genetics, but what happens is there is X chromosome inactivation to do some dosage compensation there. But it presents a really unique model for something that we've studied a lot in the lab is we might be able to use that variation in the X and Y chromosomes to better understand what is the genetic contribution to some of these things that we're seeing in behavioral phenotype. So two of the things that we looked at are Turner syndrome, and I'll talk a little bit more about Klinefelter syndrome as well. So Turner syndrome is a 45X karyotype. You have, instead of 2 X chromosomes, which we'd see in typically developing females, you only have 1. It occurs in about 1 in 2,000 live births, and it's the primary cause of primary hypogonadism in females. The physical characteristic, if you've never worked with anyone with Turner syndrome, it's associated with short stature, endocrine abnormalities. It's the leading primary hypogonadism in women. It often has cardiac abnormalities, hearing issues, lymphadenopathy, webbed neck. And it has a very characteristic neurocognitive phenotype. So full-scale IQ tends to be in the normal range in women with this condition. And often verbal abilities are in the normal range, if not enhanced. There's a phenomenon called hyperlexia, which has been reported in some women who have Turner syndrome. But there is a difference that presents, and that's really in nonverbal IQ. So in our sample, if you look at kids who have verbal between Turner syndrome and 46XX controls, they're roughly in the same range. As you probably know, any of you who do research, we tend to have controls who are never normal. Like they always have IQs that are like 110, 120, especially in the Bay Area. So it's a little bit higher here. But there is a separation in terms of nonverbal IQ, where really this is where there's some separation between the two cohorts. And this is something that's been really consistently reported in prior literature as well. Here's a nice illustration of the way nonverbal IQ might work. So you guys may recognize this prompt. It's from the RCFT, the Ray Osterrieth Complex Figure Task. And what you do is you ask someone to use it to look at visual spatial perception, right? It's a very complicated figure. They have a limited amount of time. We have to copy the figure over. Here's a 9-year-old girl who is typically developing 46XX, and she does a really pretty good job of what might be expected to reconstruct this figure. In contrast, this is a child with Turner syndrome who's copying the figure over. And you can see there's that lack of gestalt processing, right? Like the way they identify different visual features and copy it over, it gives some insight into the way they might be processing that information that's not as coherent as the other one. What you do after the RCFT is you go back and do something else. And then about 20 minutes later, without prompting them early on, you ask them to recall that same figure from memory. And that loads onto some visual memory, right? And again, you can see there's much less detail to this design for the kid who doesn't have Turner syndrome, but they're still able to at least sketch out the large structural framework of how the picture should look, as well as a few discrete details that they might remember. And with the child with Turner syndrome, it completely falls apart in a way that they're processing the visual spatial information that's much more discrete, and rather than using this Gestalt approach. So if we look at the various domains that tend to present consistently in Turner syndrome, it's what we just talked about, these visual spatial or visual motor skills. Executive function is a neurocognitive domain that's often implicated. Social cognition and behavior is also an area that's often implicated. And it's not surprising then if you look at what are the domains affected in terms of clinical frameworks, those same domains probably match onto these psychiatric diagnoses that are overrepresented in Turner syndrome. So with executive functioning, you see an 18-fold increase in ADHD. We find that there's up to 25% would meet criteria on screening questionnaires for autism spectrum disorders. And then really for the nonverbal component, we see a much higher incidence of learning disorders, and specifically within dyscalculia. Now, we have now on the other side, if you go from monosomy or a reduction in the number of X chromosomes, we have a flip side where you have karyotypes where you have additional chromosomes. And in this instance, there's something called Klinefelter or 47XXY syndrome. And what you can see here is rather than having one X chromosome, there's two. So they have both a Y chromosome and there's a non-disjunction event in meiosis where they have two X chromosomes. The phenotype is much more subtle than it is in Turner syndrome. I mean, there's probably various reasons for that. It occurs very commonly. It's actually many men don't even know they have Klinefelter syndrome until they go in for infertility testing as adults. So you can see the penetrance of this symptomatology is going to be much less. It's as common as 1 in 600. It's one of the most common chromosomal variations. And there's physiological characteristics. In contrast to short stature, men with Klinefelter syndrome tend to have taller stature than male siblings, and less body hair and gynecomastia. Interestingly, with the neurocognitive phenotype, and we'll talk about this more, there's also impairments in executive functioning, but here there's verbal skill deficits and relatively intact visual spatial deficits. So if you put these side by side, it really presents an interesting genetic dosage model, right? So what I said about Turner syndrome is both have normal intelligence, but they have enhanced verbal IQ compared to nonverbal IQ. And then in Klinefelter syndrome, you have the inverse relationship, right? And those come as a visual spatial impairments in Turner syndrome and verbal impairments in Klinefelter syndrome. They both have social cognitive deficits and they both have executive function across both conditions. And I think that's just, that's probably a reflection of how much executive dysfunction is affected in any kind of condition that affects brain development. You can extrapolate this to other sex chromosome aneuploidies. So we looked at this also with another trisomy, which is XYY, and they similarly show where the more that you have of sex chromosomes, you'll have sort of this nonverbal intact and verbally impacted profile, whereas with Turner syndrome, you have the X chromosome monosomy, where you have verbal intact and visual spatial impairments. So same thing again, really the interesting piece here is the differences in the learning disorder category with dyscalculia and Turner syndrome and dyslexia and Klinefelter, but similarities in ADHD and autism spectrum across both. So we found this in the neurocognitive phenotype, but then we also looked at brain images and we found that there's a similar inverse relationship, again, implying that not only are we quantifying these behaviors based on sex chromosome number in behavior, but also in the way the brains are constructed. So these are the relationships when you look at the volume in certain regions, so in superior parietal regions that are implicated in visual spatial skills, and then you can see this inverse relationship where girls with Turner syndrome have greater volume in these insular temporal regions that are related often to language. And then often with the Klinefelter boys, they have, again, the inverse relationship where they have decreased volume in those regions. We looked at this with connectivity analysis. This is some work that my former postdoc did, where we looked at, can you predict actually based on resting state networks, what is the number of sex chromosomes any particular individual has? We included kids who are typically developing 46XX and XY, as well as Turner syndrome and Klinefelter. And we found, in fact, that these connective networks would, in fact, map onto the number of sex chromosomes that people have. And so this is primarily in the frontal parietal networks, which is consistent with what we found with the structural data. And then in the medial temporal and the temporal insular regions, we found that the connectivity patterns also correlated with what we found with the structural data. We did a further extrapolation looking at this with mosaicism. And what that means is you can have either in the prior studies I mentioned, we did in kids who were identified as monosomic Turner syndrome. So that means when you look at their blood sample, every single cell that they counted had a 45X karyotype. So what mosaicism means is that in a genetic standpoint, that loss of this X chromosome happened later in that developmental pathway. So some proportion of the cells in an individual female would be 46XX, and another proportion of cells would have 45X. And so if this genetic dosage hypothesis holds true, we might expect to see that depending on the number of cells that you have 45X compared to the number of cells that you have that are 46XX, we could see some regression or a correlation across that dimension that maps onto what we found in 45X and 46XX females. And this is particularly important because mosaicism might just be omnipresent in women more broadly. And I say that because there's a lot of mechanisms for X chromosome loss throughout development, and there's a lot of interest in somatic mosaicism and what we call chimerism. So I won't go too deeply into that, but it is relevant for the idea of thinking about sex differences outside of just Turner and Klinefelter syndromes. And when we did look at this mosaic model, we found that in fact you could predict by the degree of mosaicism, you could predict the degree of mosaicism, by the brain patterns and neurocognitive phenotypes. And so if you look at these figures over here, you can see that having 100% in mosaicism, or in this case, 100% is representative of 46XX cells. All of your cells are considered typical karyotype, compared to having 0% mosaicism or 45X cells. All the ones in between are the individuals that we characterize as having mosaicism, sort of fall on this regression dimension. This doesn't happen all across the brain or in all neurocognitive dimensions, but it occurs in only a few of them. And those really, again, visual spatial skills, somatomotor functions, and then again in the frontoparietal and superior parietal regions, again lending some weight to the idea that there might be a pure biological and genetic basis for some of these differences that we're observing. So just to wrap up the genetic piece, it's unlikely that these are driven primarily by hormones. All of the data I presented to you were in prepubertal samples. So if we really think of the hormonal differences as emerging in adolescence, there's clearly hormone differences in utero, which we can't control for. But at least for boys with Klinefelter syndrome, those hormonal differences don't emerge until puberty. So there's a strong argument to make that these are pure genetic effects that are, at least in the boys with Klinefelter syndrome, that are driving some of these differences that we're seeing. And in fact, we went in and looked at this in a genetic model. We can use stature or height as a good example of this. If there's a gene dosage effect, there's going to be extra genes. If you have 3 sex chromosomes compared to having 1 sex chromosome, you should see certain traits progressively have those height differences. And in fact, that's what happens. Turner syndrome, I mentioned, they have shorter stature. And in Klinefelter syndrome, they have taller stature. And that probably links to a gene called SHOX. So if you have in this pseudoautosomal region that's not inactivated, men with Klinefelter syndrome have 3 copies of SHOX, and girls with Turner syndrome have only 1 copy, and hence stature is related in a dosage-related effect, right? And so we can extrapolate this also into cognitive function, which is what we did in our sample. And we got the peripheral blood of our sample, and we saw that, in fact, you can see the separation that shows a very dosage-based compensation for how these genes are expressed in the transcriptome across a number of genes that were on the X chromosome, as well as genes in the autosome. All right, so hopefully that provides a little bit of a framework for really the genetic piece of how we can think about sex differences, and particularly how we can think about it from sex chromosome complement. I'm gonna switch over a little bit and talk briefly about the hormonal effects. So we know that in development, sex hormone profiles are not equal throughout, right? It's not as if there's kind of just a flourishing of testosterone throughout in males and a ton of estrogens in girls throughout development. In fact, it happens in these developmental windows. And those developmental windows tend to occur in puberty. So here are circulating sex steroids across an age range between early 5 years old through 18. And if you look at the distribution of testosterone, again, in childhood, which overlaps interestingly with that male-female equivalence period for mood and anxiety conditions, but also from a psychological perspective, we call this period latency, right? And there's very little differences as far as hormone profiles. It's really only in boys during the pubertal period where they start to have this spike with the onset of adolescence and testosterone, and to a lesser degree that happens in girls. And the converse is true for estrogens. If you look at estradiol, there tends to be a huge spike in adolescence for girls and very little increase in boys in that equivalent period. One way to think about this then is another area of research for our lab, which was thinking about transgender health, right? And this is a unique opportunity where we wouldn't otherwise normally give estrogens or testosterone exogenously. There are certain endocrine conditions where that might be the case, but this is really a very distinct paradigm where we could think about these conditions in youth. And the prior studies are really limited as far as being able to understand this. And I say this because almost all the prior literature has been done in adults. The vast domain of neuroimaging work has been done in Europe, and they tend to treat children who are much older. So for example, the Dutch group has the largest samples right now, and a lot of the kids that they treat as a reflection of the way they do their clinical protocols is that they tend to be in later stages of puberty, so 10 or 4 or 5. In this particular study, we're collaborating actually with your colleagues here at UCSF, Steve Rosenthal, Diane Arensef, Jack Turbin here, who are all in the pediatric clinic, and then as well as the gender clinic down at Stanford. And you can guess from the milieu of Northern California more generally, people are much more flexible here, both parents and practitioners, as far as doing interventions or gender affirming hormone therapy at younger ages. So what we did in this study is we would collect those kids who were at the earlier stages of puberty when they started gender affirming care and did some scanning. So I'm just going to present some of our baseline data. But we know already in this population of youth, and this is actually Jack's review, is there's a higher mental health burden in trans youth, right? Like there's a higher incidence of mood disorders, anxiety disorders, and then unfortunately, there's also a higher incidence of suicide attempts. So if you look at this, again, there's this developmental correlation to adolescence where it increases substantially in later adolescent periods. And this is going to be highly complex, and we can't deconstruct all of that here as far as what are all the factors that load onto that. But it is a good argument that there's probably both gender and sex-based factors that are leading to these. One of the things we do know, if you look at the adult samples, this is one of the seminal studies in transgender literature, is that satisfaction vastly improves with intervention, particularly with surgical intervention, right? So the characteristics around mental health, well-being, and behavioral scores all drastically reduced after reassignment surgery. So if we look at this construct within early puberty, what we found are probably, if we're trying to find in neuroimaging some sort of correlation in the brain for the experience of gender, that's what we would find in this baseline time point that I'm showing you here, right? This idea that kids who have not received any external or exogenous gender affirming care, they haven't received exogenous estrogens or testosterone, they are in fact only socially transitioned at the point of entry into our study. And in fact, if you look at the brain signatures, at least structurally in places like the amygdala, there aren't significant differences yet that are emerging. So another way to interpret this is kids who identify as trans female would be more similar to their peers who are cis males or assigned male at birth. And then kids who identify as trans males are more similar to their cis female colleagues, right? And this is in several domains, whether it's in the right and left amygdala, and whether it's in other subcortical structures like the putamen. We interestingly found a slight difference in the insula, but it's unclear yet what the significance of this will be going forward. We'll be coming out with longitudinal data, which I think will give us a much clearer inference of how to separate some of the things related to sex and related to gender as constructs. I want to point out some behavioral findings from the sample. we looked at anxiety and depression scores. Here we operationalize that as mask for the anxiety measure, and then for depression we use the CDI. And on the left, in both of those measurements, you can see the cisgender kids are in kind of a non-clinical range, and there is a higher mental health burden even at baseline. So in our baseline time point, this is prior to them getting any hormone therapy. And there is, again, in anxiety, you would see that it's just subclinical threshold, and then it's approaching the clinical threshold in the mood scores in the gender diverse kid cohorts. Again, we're not sure what to make of this, right? Because these are kids who are expressing gender dysphoria. So to call it mood and anxiety versus gender dysphoria is a really difficult construct. And we'll see as they're going through whether these anxiety and depression scores hold true. One of the interesting findings that I just want to point out is we did correlate those mood and anxiety scores against the overall family gender environment. So just a measure of how supportive the family is. And we looked at it at the age at which they said they socially transitioned or they came out. And contrary to a lot of literature which suggests that there's a tight correlation between how supportive the family is and the experience of mental health burden, in our particular sample, they weren't tightly correlated. So these were not significant regression factors. And our inference is there's a really good reason for that. We're specifically selecting for kids who are about to embark on transition, right? So by nature, the only people we've included are kids who are convinced already about their gender identity at a much younger age than kids who are adolescents and maybe struggling with this for a longer time. And their families have already agreed to proceed with treatment. So it's not necessarily surprising that we're not finding a correlation between those things, because family support scores are high across the board. And so the other way to think about this, which will be interesting in our later results, is if you pull out at least some of these family stressor or environmental variables, this might be an indication of anything that we find in the longitudinal data going forward is really related either to the biology or directly to gender identity itself, right? Like that's one way to think about it. That's one interpretation that I think we can make from this baseline data, is that we can isolate some more of the impact of gender. Again, almost impossible because there's a non-alignment between gender identity and physical characteristics of the body, but we are picking pre-pubertal youth or early pubertal youth who haven't had a lot of secondary sex characteristic development yet. So that will be forthcoming. All right, so just to wrap up, again, this is one of the first studies that we're looking at in early pubertal youth. This is some preliminary data, and hopefully, in a few years, we can give you some more interesting results of how this looks like longitudinally as they go through treatment. The way to think about, to just encapsulate everything we've talked about sex, and we've talked about gender. So there's probably really these significant sex differences in brain regions, and that particularly centers on the frontoparietal networks, temporal insular networks, and these are likely related to early development and sex chromosome genes. We also found that over time, there's going to be these hormone-related changes that are likely happening in utero, but then reactivated in the adolescent period. And these follow certain kinds of models where you might see this in gonadarchy during the pubertal period, but also in menopause. And then lastly, we're just touching now on the idea that gender expression just occurs throughout this entire period. And we don't have a really great way of quantifying how those interact with those other things that we're seeing in terms of genetics and in terms of hormones, right? So there's a number of things that people are looking at. Jack's looking at different things in the transgender population around minority stress, your individual experience of how you're perceived by others and how you internalize those things and how that might manifest even in neural signatures, but also observer effect and expectations. We talked about that in how autism or ADHD is diagnosed, is there's an external perception of how symptoms present in children and adolescents that hugely influence how we react to somebody, right? And those are clearly intertwined. So we're going to conclude on this concept again of how does this relate to child psychiatry more broadly? We do have this heterogeneous problem, where we have a ton of variation between two people. And if we can think about it biologically, we'd like to think there's a one-to-one simple correlation. We're all slightly different in our phenotype because we're all slightly different in a genotype. And if we can just find the right genes that correlate to the right subtype of any condition, job done, we're going to move forward. But the reality is it's much more complex than that, right? We have way more complexity and interplay between something that's happening at a core genetic biological level all the way to the expression or manifestation of behavioral symptoms. And what I'm going to argue as our takeaway from that is some of that complexity, or one of the greatest contributors to that complexity or inter-individual variation, is really sex and gender, right? Sex is probably one of the most robust quantifiable factors that we can point to or identify in research as an inter-individual factor. And gender is equally important, but we have much poorer tools right now in research constructs of how to operationalize that. So probably in all your grand rounds, and what's just kind of very of the moment right now is talking about N of one or personalized psychiatry research, right? In order to do that, we have to move away from these group-based constructs or just diagnosis-based constructs. And I would argue probably the most proximal factor that we can advance some of that work is to start thinking about sex and gender, both in our clinical work and in our research. So ultimately, we have a lot of problems about how we tailor treatment to the individual. We misdiagnoses, we misdiagnose. There's a delay to treatment in many of these conditions that particularly disadvantage females. We have ineffective treatment trials and drug response. We have adverse side effect differences. These are really critical things. And we go back to the idea, maybe there's only 1% difference between males and females. If that can somehow inform some of these glaring gaps of knowledge that we have in clinical practice, that could be a useful thing. So with that, I just want to thank my collaborators, including Dr. Rosenthal, who's here at your institution, Tandy A., and others in the lab. Thank you very much.
Can folks hear me? Great. Okay. Q&A. And I want to remind folks, one question per person, so we let folks have a chance, other folks. And you're the first person.
Thanks very much for really interesting talk, and I applaud you for your recent research applying objective measures to the study of transgender youth. But I came away worried with regards to your interpreting brain volume differences after you just told us about the slew of comorbidity that is, of course, found so commonly. How do you deal with that? And maybe another approach might be less influenced by that, might be neurocognitive profiles, perhaps.
Yeah, I think that's a really great point. And my take, and I'm going to invite Jack also to comment if you have different thoughts, because you're doing this more broadly in exactly what you're talking about, neurocognitive and behavioral research. That's sort of the state of the field right now, in the sense that we can't separate out all of those other confounds that you're talking about, right? We know that mood and anxiety scores are higher. There's a ton we don't know about gender dysphoria, how that impacts, for example, what I look at, which are these neural networks, right? Whether it's volume or all those sorts of things. So we're doing the best with what we can right now, which is, in our particular study, we're including all cohorts. We didn't even talk about other confounds in terms of sexual orientation and how to interpret that in youth. And, there's all this lived experience around how long you've lived in different gender identity versus kids who decided to do it later. And so, to your point, we need to do that work. My argument would be we're one of the first neuroimaging studies in adolescents in the US that's been funded to do this. And so what we're eventually going to need to do is build up a corpus of neuroimaging data. And obviously the NIH is moving towards that and having shared data repositories where you could answer that more broadly. Also, the ABCD data set is 10,000 kids, right? And a big number of those have diverse gender expression. So we probably could do this to scale once we figure out some of the central tenets. But those are too closely intertwined right now. And I think you're right. Like, we're only going to answer some of the more subtle complexities in the future. Yeah, it's an inherent limitation.
I had a question that's about visuospatial reasoning and testosterone. So I see your argument for it being more of these genetic factors that are driving the difference that you see, but I'm stuck on thinking about the biggest meta-analysis that I saw about the impact of gender-affirming hormones on cognitive domains. The only thing they found was that visual spatial reasoning improved among trans men taking testosterone, and that was young adults. And then also thinking about differences of sexual development. So people with congenital adrenal hyperplasia having better visual spatial reasoning than those without, and those with androgen sensitivity syndrome having worse visual spatial reasoning than those without. Do you think it's both? Or do you really think it's mostly these genetic factors and influence early development?
That's a great question. I do think it's both. It's both. And I say that because with Klinefelter syndrome, they don't have that testosterone insufficiency compared to their 46XY peers until adolescence, and yet they still demonstrate this difference. So, the putative reason for that is that there's going to be a genetic difference. But exactly to your point, any of those viralizing conditions that you mentioned, there tends to be this observable change in that visual, spatial, and visual construction dimension. I think really highlights that testosterone could play a big impact in that. So I appreciate that. And yes, I think it's going to be both factors. And that's probably that particular task is probably one of the most robust if you looked at a psychological outcome that does have a reasonable effect size. So yeah.
You mentioned personalized medicine that could be like gender could be, sex could be used to help inform that. So I don't know if there's been a study that looks like that clinical trials and aggregating all the data. Are there any differences emerging with how people are taking or responding to medications or other kinds of clinical trials?
That's a fantastic question. And for decades of research, particularly for drug interventions, we've only included men, and then we've then said, okay, women, you too. We're also going to give you statins or whatever, right? But we can probably get the best differentiation of those things and outside of our own field, sadly, right? So we know, for example, myocardial infarction, the symptoms might look slightly different in women than it does in men, right? And so now there's a number of clinical trials in various fields that are focused exclusively on looking at symptom manifestation and also treatment interventions in women compared to men. And that is a mandate over the last 5 years by the NIH. You have to account for sex as a biological variable every time you apply for funding. So to your point, yes, we've come very late to the table with those kinds of constructs, and it's absolutely that work is being done now. So we should be doing it. We know for a fact, we can extrapolate those same principles to the way we express anxiety, the way we express psychosis, the way we express depression. There are probably are a lot of similarities between males and females, but also very significant and relevant differences, right?
Yeah, kind of related to that, I'd be interested in your thoughts on, I guess, best practices for studies in terms of determining sex and gender in their populations. I'd be curious in the Danish study you used at the beginning that was showing the sex differences in terms of different mental illnesses. Kind of, do we even know how they determined male and female in that study? And kind of what you think would
that's a great question. And I think really for anyone here who's interested in that research is really how do we quantify the experience of gender, right? So for sex, at least for the Danish study, they're using national cohort information. It's probably just what's in the medical record as far as the assignment at birth. You can talk about it on a small science scale, these variations in ambiguous genitalia or these various conditions that we're talking about as other ways to think about sex, not as a monolithic construct, but even within sex, different expression or variations in sex as a biological variable. But really the construct of gender is the area where we have a horrible way of saying okay, what are the way to quantify gender roles? They do this in some large scale economic research as far as the equality between men and women in political spheres and economic spheres. Obviously Scandinavian and Northern European countries really benefit from having a distribution of household responsibilities versus the number of people at work or how you get compensated. And there's a couple of gender indices that are emerging. I've seen this also in cardiovascular health, how does your cardiovascular risk relate to the role that you play in the home as far as distribution of labor and things like that. So we absolutely need that. And I think it's tough because it's a moving target, right? Even generationally, I work all the time with my team, and I'm like 2 decades older than them, and I can tell we already have very different starting points of how we conceptualize gender at all, and their experience versus my experience. So it's tough to construct sometimes sociocultural variables that are going to evolve so quickly over time. So.
On that note, we have a question which you probably won't have enough time to answer. So I'm gonna go ahead in the interest of time. How generalizable are the results of this study to Black and Brown youth, given that the study population is from Denmark? I understand it certainly has heuristic value and beyond, of course. Great presentation.
Thank you. Yeah.
Thanks, Yvette, for that question. Sorry.
Yeah, this is someplace that we were horribly impacted by COVID ourselves, as far as trying to do really good distribution of recruitment. Unfortunately, we are underrepresented in our sample. So if you have a lot of Latinx or African-American kids who identify as gender diverse and want to refer them to us, we'd happily include them as participants. But this is something that we really need to use, right? Like, we can't just use Northern European data for a much more diverse or heterogeneous population, such as in the US. That being said, at least on face value, some of the similar trends are observed also in those sex differences and those developmental differences, even in the US population, which on the face of it does sample across race and ethnicity.
I'm going to use this
Great.
mic so that
Yes.
folks on Zoom can hear me. Thank you very much for your time, and it's been a fantastic and such a pleasure to have you with us today and walk us through all of this. And you have to come back. There's more to be done. Take good care, everyone.